This is the International Foundation for Integrated Care Canada's virtual community. We are the North American Center for Integrated Care. We have close to 400 people registered today, so we'd like to give everyone a chance to log in for those that are able to make it who signed up. Please say hello to your fellow guests and participants. We are at 100 people and we expect to go much higher. A warm welcome. Many of you I know, some of you I don't, but I am particularly excited to be sending a warm welcome to all of you across the country, across North America, and in other countries around the world. Welcome to our virtual community. Our topic today is the critical role of partnering with the volunteer sector to enable integration. We are welcomed by many wonderful guests, and our goal with our virtual community is to share information, share knowledge, and build capability across all integration efforts in North America and across the world, as part of being joined by the International Foundation for Integrated Care Global and our hub, the North American Center for Integrated Care. So a warm welcome to all of you. Deb, to the next slide, please. First, how did IFIC Canada come to be? Well, I'm Jodine Goldhar. I am one of the co-founders for IFIC Canada. I sit on the board of directors for the International Foundation for Integrated Care, our global body, and serve as the treasurer. I also help convene, facilitate, and build knowledge and capability for integrated care that enables population health. And I am proudly co-founder of IFIC Canada with Walter Watchis. Walter, please
welcome. Welcome, everyone. And I am Walter Watchis, and I am so pleased to be here with Jodine as we bring forward the Integrated Care for IFIC Canada series. We're aligning this with work that many of you are familiar with through the Health System Performance Network. So I am co-founder for IFIC Canada, professor at the University of Toronto, and many of you know me as the principal investigator for the Health System Performance Network, where we are leading research in integrated care and also advancing the evaluation of Ontario health teams. And we have a regular webinar at this time. So welcome, everybody. Please type into the chat. If we go to the next slide, and Jodine will take over again, so that you can introduce yourselves to us. You should have access to the chat to do so.
Just a couple pieces that help enable the success of the kind of collaboration we want to have today. We will be actively using the chat. When you use the chat, please ensure you're responding to everyone so that we can have a shared collaboration. We also want to engage people that are not able to attend today. So we have close to 400 people register. Obviously, not everyone can attend when they register, not knowing how each of their days will go, but people do participate and look through social media and want to be part of the conversation. So feel free to tag Walter and I, IFIC, the International Foundation for Integrated Care, and hashtag IFIC Canada. We will put the Twitter handles and our other handles in the chat so you can access it. And please feel free to share anything. You need to know that the the PowerPoint presentation and our conversation is going to be recorded and will be available to share with a much broader community. And as you can see in the chat, which is a wonderful way to feel the energy of everybody who is joining us today, look who is on. We have people from all over Canada, some across the States, and definitely a global audience. When we run these virtual communities, we often have up to 52 countries participating. Let me tell you a little bit around our global audience. Deb, if you could please change. And you could also see, as you're coming in the future, in the product that we produce coming out of this, we will do a map of where everyone is coming from, what provinces, what countries, and where from. We have a full range of policymakers, funders, we have national and international organizations, and then we have people joining from particular integration efforts in whatever country they are coming from, both the participants and those that will be sharing knowledge as panelists today. Our goal is to convene our collective community. We run from the principle that we have the capability together to be able to break down the silos, create integrated care, and co-design the answers to enable population health and well-being, no matter where we are around the world. And with that, I'd like to turn it to Walter for a land acknowledgement.
Thank you. And I can see from the chat that people are joining us from across Canada and internationally, and particularly in Canada, we have a tradition of appreciating and acknowledging that we are using the land that was originally traditional territory of many nations that have resided here for thousands of years. And I'm hosting this from Toronto today. And the land in Toronto is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa and the Haudenosaunee, and the Wendat peoples. And we acknowledge that Toronto is covered by Treaty 13, the Mississaugas of the Credit. As I mentioned, Canada is home to many diverse nations. I welcome you to acknowledge the traditional lands and the treaties that are you or unceded territories in some cases. We're grateful to be able to come together in this way. Thank you. I'd like to know now for you, it's a first little opportunity for us to engage with you. If this is your first time joining the IFIC Canada virtual community. And so you can go up and chime in on your votes. And people are quite quick on this. That's fantastic. We have 150 people online now, so we'll look for everybody to be able to respond to this question here.
One of the reasons we do this poll is we like to Sorry, everybody. One of the reasons we like to launch the poll is we like to track over time, both continuity and being part of the program, but also to being part of the virtual community, but also ensuring that we connect with people who haven't joined, so we continue to build the movement and the collective ability for us to come together. Fiona, are we ready to launch the results? Okay, so out of 150 people, it's pretty amazing. 62 have joined us before and 45 are new. Well, a welcome to those that have returned and a warm welcome also to those who've just started. We hope that in the future, you can, if this brings value and helps, you believe helps build our knowledge and capability to do this work and to make a meaningful difference in our communities, then please feel free to stay part of the community and share as we grow. Let me tell you a little bit about the virtual community itself. So the virtual community, we have a number of principles, and the reason we mention this up front is because Walter and I believe firmly that even though there is so much great integration work happening in North America and around the world, there are not a lot of places and spaces that convene us to learn from each other. And so the International Foundation for Integrated Care does it on a global scale, and us being the North American hub on integrated care, we do it on a North American scale across North America and with the rest of the world. And we have a number of design principles in how we do this. The fundamental piece is that we do nothing without being in equal partnership with patients and caregivers. And we also come together in shared purpose across wherever you work in health and social care, regardless of role, hierarchy, and position. We have the capability to do this work, but we have to bring together our full capability to do this. There is a link which you can access on the International Foundation for Integrated Care website that will give you access to all of this. We launched the virtual community in 2019 pre-COVID. And I want to share a couple of the sessions we had so you know what you can go back and look at that would be a resource and is a free accessible resource for everybody on the IFIC website. We started the virtual series with a tour on integrated care around the world and what it means. Similar format. We had approximately 52 countries online at the time. We had a number of presentations, and you can have access to all that information. The next is, because of the founding principle for the way we work, which is a new power approach, where we share power equally with caregivers, patients, clients, citizens, to not just deliver on our sessions, but to co-design the answers. So we did a session on how to do that and what does it look like around the world. Next, we focused on the central role of primary care as an enabler for integration, and we looked at a global review and what's happening around North America. And then finally, we looked at digital health and technology as an enabler for integrated care and population health. Then for the integrated efforts that are happening throughout North America and the world, how do we look at both the spread and scale and sustainability of each? And finally, we focused on shared governance, both collaborative governance or collaborative leadership across health and social care leaders and collaborative governance across health and social care governors. And today we are focusing on the volunteer sector. So again, you can access all of that on our website, and Walter and I serve as resources to you because we believe all of this material is accessible and has to have no barriers to access. In addition, we did the first North American conference on integrated care. It was focused on innovation, inspiration, and imagination and integration by co-designing health and well-being for individuals and communities. All of the keynotes and the panel discussions, along with all the content and presentations, is on the website as well and is fully accessible to you, including videos that you can use with your teams wherever you're at to help mobilize and advance further capability and knowledge to deliver on integrated care. And with that, I now turn it to Walter.
Well, we are super enthused today to have the opportunity to focus in on a new area for us and the critical role of partnering with the volunteer sector to enable integration. And I've done quite a bit of work in the space of integration, and we're often talking about integrating health and social care and trying to support individuals and community. But really, oftentimes what's really happening is that people are being supported by their caregivers, and supports to caregivers themselves often are lacking. And I think we're going to hear some really excellent and amazing examples today of reaching out to the third sector, the voluntary sector, who are really playing a role in supporting patients and caregivers in the community and in maximizing their ability to maintain independence as they require many services. And we're going to hear some really excellent examples today. On the next slide, we talk about a few of the pieces that we're really trying to communicate today. One is to talk about the evidence and research that supports the role of partnering with the volunteer sector to enable integration. And we'll have Dr. Michelle Nelson speaking about that, to identify the role that the volunteer sector plays in policy and program delivery. Dr. Richard Levancek has some awesome and excellent examples. Understanding the highlight the successful approaches to partnering with the volunteer sector and the impact that it can have. And we are so fortunate today to have Vicky Irons here from Scotland, where they've been doing this work at scale for many years. And then really to understand what difference does this make in caregivers and patients' lives. We are very fortunate to have Bryna Ludwig-Prout with us today to talk about that and bring it to life. So let me introduce those individuals just for a moment here, and I'll start with Bryna, who will speak last today. Bryna is a change project and program management expert with over 20 years of experience as an independent consultant, specializing in large and complex projects. And she's a certified human resources leader. But today, she'll be speaking from her perspective that in the past 6 years, Bryna's been a caregiver, become involved with many related activities, and she's really contributing to the health system in this regard. Currently co-chairing the Hennick Bridgepoint Hospital's Patient and Family Advisory Committee, has past roles in the steering committee of the Change Foundation's Change in Care project, and has presented to diverse audiences on the importance of engaging with caregivers. So very fortunate. Really looking forward to hearing from Bryna. Vicki Irons is the Chief Officer, Dundee Health and Social Care Partnership, and she has over 30 years of experience in the NHS and NHS Scotland systems in government and delivery. And she also was the chair of the National Forum for Integrated Care Boards for Scotland up until 2021. My good friend, Dr. Richard Levansak, we've spent a lot of time together this fall working on some research proposals together. He's the medical director of the Health System Integration for Alberta Health Services, and if you want to know what's happening in Alberta Health Services related to integrated care, you need to contact Dr. Richard Levansak, because he just really knows everybody and what they're doing everywhere across that province. And he received the Integrated Care Award at the International Conference for Integrated Care in San Sebastian on behalf of Alberta Health Services for doing some amazing work in this space a few years ago. And first up for us today is Dr. Michelle Nelson, who's a scientist at the Lunan Tannenbaum Research Institute at Sinai Health Systems and an associate professor at my home at the Institute for Health Policy Management and Evaluation at the University of Toronto. Aside from that, she's also the Chief Knowledge Officer for the March of Dimes Canada. She leads a program of collaborative research focused on integrated health services for people with complex health needs, with the emphasis on intersectoral collaboration and the role of volunteers in the voluntary sector. Perfect for us here today. And is a senior associate of IFIC and chairs the special interest group for the voluntary sector in integrated care for IFIC. We are going to also introduce on the next slide people making this happen in the background. Great thanks to Tricia Martin and Ded Golub on our team, Niamh Daly-Day and Fiona Line from IFIC Central as well, who have really enabled this. So just before Michelle starts off, one more poll, and that is really to get a sense of where you are at the start of today's, and your knowledge, how knowledgeable are you about the role of partnering with the voluntary sector within an integrated delivery system? So if you can answer into this poll, how would you put your knowledge from not knowledgeable at all to very knowledgeable? And so I look forward to hearing reading your opportunities here. Okay, polls are coming in. And, oftentimes we start these off, this is a novel topic for many people. I know I've been educated over the last number of years from many of the people today joining us. And it was new to me to understand kind of what the opportunities were. And I've even in preparing for this event, learned a lot about the initiatives that are actually taking place. Okay, I think we can, the polls are still coming in, but they're slowed down a lot. So we could probably pop up the results here. And here we go. So we have a bit of a spread, about a quarter of the people being right in that middle area of somewhat knowledgeable, and then almost an equal proportion on either side of that, I'd say. So what an opportunity for us to learn today. And those people who have had more experience, please join in the chat and share with us what you know and how you've learned, because we always learn much from the chat and what you bring to our events as well. So thank you very much. And from here, I think we can go ahead a few slides, because I've already introduced that Michelle and then Richard will go, followed by Vicki Irons and Bryna Ludwig. So if we start off with Michelle, the floor is yours.
Thank you so much. I'm really excited and honored to have the opportunity to speak to the group on this important and timely topic. So I'm going to just start by saying that, and I'm going to give you, in 10 minutes or less, I saw a question around definitions already. So we're going to talk about definitions to frame the discussion. We're going to talk about the scope of the opportunity, particularly in the Canadian context. I will share a couple of frameworks that might be helpful for kind of current thinking, future discussion, and then talk about the nuts and bolts, opportunities, motivations, challenges that people experience when they do this work, hopefully spark the discussion and lead into my fellow panelists. So next slide, please. During this discussion, if there are in fact opportunities in the chat to put in, what was your most memorable volunteerism opportunity? Was it formal or not formal? If you haven't volunteered in a while, what's in your interest portfolio? Why are you here today? What are you hoping that we're going to talk about? And if we don't address it, then perhaps we can follow up with additional material on HSPN. So what are we talking about when we say volunteers? And in the Canadian context, in 2013, in a survey, we would have said 47% of Canadians volunteer. So those who give their time to formal organizations in service to the mission. And that would have worked out to be, just over 1 million full-time jobs, and that would have been within one of the many 800,000 plus registered charities in the Canadian context. In 2018, the survey definition was broadened to talk about informal volunteerism. Are you helping your friends and neighbors in a way that doesn't get captured? And when you do that, more than 80% of Canadians over the age of 15 say they volunteer to support health and well-being of their fellow citizens in their community. And so I gave you a chart to show the number of hours that are being allocated to various sorts of organizations. And it's going to be interesting to see what happens post-COVID with the incredible rise of community response and mutual aid. And so I provide this as an opportunity for us to frame the discussion. Next slide, please. I saw there was a question around what do we mean by volunteers? I like to use the WHO definition, which is anyone who is working in human resource for health and who are paid, unpaid, or volunteers. And that's a 2009 definition. Now, of course, we have to think about what do we mean by the voluntary sector, the third sector, where does that sit? And so, I've had participants of studies say, we're really talking about the organizations that are both a destination, we think of it as a destination, but they're also our partners in supporting health and well-being. And someone said to me, well, these are really the services that are close to where you work, play, and sleep in your own bed. And so the idea of what are the characteristics of those third sector organizations, I've provided them to you. Third sector is a term that has been used to describe organizations that are not public nor private, and has been used to describe nonprofits, think tanks, registered charities, self-help, mutual aid, social enterprise, etc. And so those are the characteristics of. I would be remiss if I didn't point out, though, that the context of third sector is grounded in the socio-political context of your locale, and I'm hoping that Richard will probably flag on that in the Alberta context. Next slide, please. So Emma Sachs and colleagues, noting that community health was identified in the UN Global Health Strategy as an essential component of system resilience, noted that in the WHO health system framework, it was insufficiently addressed. And so they have repositioned this and convened through a convening of a like-minded collaborative group, have positioned where community may sit in the building blocks. And so I've given you the citation. The framework is really helpful. It's also really helpful for policymakers thinking about how to recognize, prioritize, and invest in the aspects of health systems that could promote broader considerations for health. I'm not going to go into great detail on that. The next slide provides a nice framework to talk about what is community-centered approaches for care. And this is a framework that came out of Public Health England, the NHS and Public Health England. And it's really the idea about focusing on and thinking about community assets to promote health and increase access and equity considerations. And so they've positioned 4 broad buckets, and it's a family of framework. So I'm going to be interested to know if the experiences that you have in your volunteer opportunities, if in fact they align to any of these. And I'm sure many of you on the call either are working or have worked through services that align to one of these. For example, I saw colleagues of mine talking about pathways for participation. The idea of social prescribing is a great opportunity to think about pathways to participation, third sector engagement. So, much of this is really built on the assumptions that the interventions held within this framework can reflect partnerships and a support integration. Many of these domains have great examples of community-centered practice, and I suspect Vicki will flag this, that one of the challenges that they're now sort of seeking to address is the scaling up of these approaches, the diversity of grassroots responses to the direct needs of their citizens and community members, and then to determine how you do that at scale and where it links to the more formal established healthcare services. So I provide these two frameworks because they're two of the ones that I use a lot. If we go to the next slide, I just want to talk for a minute about the promise and challenges, the promise and pitfalls of collaboration, intersectoral collaboration with the third sector, the voluntary sector, as it's often called. You know, this isn't a new concept, and we have talked about collaboration across sectors and services to support addressing public health challenges, smoking cessation, for example. We look to intersectoral partnerships to address inefficiencies or talk about resource availability and considerations. We talk about leveraging the expertise and opportunities for the extension of or meeting the needs of citizens where they are. We talk about in the intersectoral, the motivations, we talk about how do we do more and align our work for collective impact, that idea of that we're all working to the common good. I put the expectations in reality, and you can see that both arrows actually eventually make their way out to, you know, pointing in the same direction. But there is this challenge and some struggles in the collaboration. And so I suspect many of you in the discussion or Q&A will identify some of these. But collaboration doesn't exist in a vacuum. You know, we need to think about the collaboration between the sectors and evaluate them within the context that you're working in. You know, there's a substantive literature. If you have Googled, scholar searched voluntary sector health services, there's thousands upon thousands of articles, but it sits across clinical, social care, voluntary sector, gray literature. And so it's difficult to find the articles to inform your approach. We often see differences in philosophical alignment, approaches to collaboration, decision-making processes, competition for power, the resource asymmetries, who has and who doesn't have a lot of resources, service philosophies, and accountability considerations between the organizations. And I suspect Richard and Vicki will have lots of comments on that. One of the things that's really interesting is that in the literature, it's hard to find evidence of impact. There's a systematic review that was just published. If anyone's interested, I can share that, that noted that there's evidence around collaboration, but not evidence for health impact. And so I wonder, you know, that's an opportunity and a gap that we can address. And then the scalability, and I think we'll hear examples of that. What I wanted to flag, though, before I finish my 10 minutes, is that, you know, despite the conversation, despite the evidence, despite the ongoing international conversations, we're still under recognizing. We're under studying, under recognizing the potential value. And so this webinar and other work allows us to address that, bring it to the fore. And so the next slide, please. So if you are sparked, if you have interest and this has whet your appetite and you want to dig in, join this special interest group through IFIC. I've given you a QR code that'll take you to the sign up page, or email me and let's continue the conversation. Thanks again for the opportunity for this whistle-stop tour, and I will pass it back to Walter.
Wonderful. Thanks so much, Michelle. What a wealth of information and knowledge. And I see people have been putting in some chats with examples, suggestions, and ideas. Please continue to do that. We will actually monitor and provide some feedback along the way, virtually on the side. And also we'll be taking up questions and answers towards the end. If you move to the next slide, we're going to move right into Richard and his summary of some of the volunteer sector engagement in Alberta. And they have examples at scale across the province. It's really amazing what's happening in some of the initiatives out there. So over to you, Richard.
Thanks very much, Walter. Really enjoyed Michelle's talk, and I hope to build upon some of those points. So we could go to the next slide. This slide isn't a formal poll, but it's just to get you thinking about what percentage of healthcare is actually provided by the formal healthcare system that we hear about on the media these days. Is it from 90, 70, 50, 25, or 5? You can probably guess that actually the formal healthcare system only provides somewhere between about 3 to 5% of care. Next slide. Turns out that 90% of care is provided by family caregivers or in the form of self-care, but that's another talk. So that leaves 10% of formal care. Now, of that 10% of formal care, 70% of that is provided through the volunteer sector. Next slide. Well, in our province of Alberta, we have about 1.4 million volunteers out of a population of 4.5 million, but we have over 26,000 not-for-profit volunteer and charitable organizations. Those are registered. So it doesn't include religious, community, school-based, or individual volunteering. 175,000 people employed in the volunteer sector and estimated to provide $9.6 billion of economic benefit. Next slide. So why does a health system, so I represent the system, so why would the system be interested in working with the volunteer sector? Next slide. And next slide after that. So I wanted to highlight some case studies. So if you bear with me for a minute or two, I'm going to show you a little bit of our logic. So this slide can apply to any healthcare system in the world. And what it says is that there's a small proportion of people to whom a large proportion of costs are attributable. So we call it the 565, 5% of the population to whom 2/3 of healthcare costs are attributable. So next slide, and then next slide after that. So who are these people? Well, we often think that they're the drug addicted, schizophrenic, homeless street people, but in reality, they're not. It turns out that these people are either frail older people or older people with multiple chronic conditions. Next slide. So the next thing that happens then is the healthcare system will say, well, why do they cost so much? And it turns out the reason they cost so much is because they end up in a hospital. They're the largest users of the hospital acute care system. So next slide. So when we ask this question of why do they end up in hospital, this is where a fatal error occurs, because most health systems will give you a list of diseases, things like heart failure or chronic lung disease. And so in response to that, we set up more heart failure clinics, hire more cardiologists, and absolutely nothing changes. Next slide. So one of the things we did is that we worked upstream to say, why did this person really end up in hospital? And what we heard was a totally different story. What we heard was, well, medically, maybe this person didn't need to be in hospital, but what? But I couldn't send them home. They weren't managing at home. I knew that if I sent them home, they'd be right back. So what we were hearing was that the resources needed to look after these people in the community either, next slide, didn't exist, weren't known, or weren't coordinated. With 26,000 volunteer organizations, you can probably guess that the doesn't exist doesn't apply. It's really, we in the healthcare system aren't aware of them, and we're not integrated. Next slide. So here's some actual data. We looked at hospitalization, which is the biggest driver of costs in our healthcare system by some of our 103 local areas. And you can imagine that in your local area, the greater the proportion of elderly people, the higher the hospitalization rate. So it makes sense. And we see that here, but the dots are all over the map in terms of age of the population and hospitalization. Next slide. Instead, though, if we then look at the resource availability in those local geographic areas and the hospitalization rate, look at what we see is that the fewer the community resources, the higher the hospitalization rate. Much better predictor of hospitalization than the actual age of the population, showing the importance of community resources. Next slide. So if you can't interpret this slide, that's okay, because it means absolutely nothing. So with medical administrative data, we've tried to predict hospitalization. Can we predict who's going to end up in hospital and therefore intervene? Turns out you cannot predict hospitalization with medical administrative data. But next slide. But in reality, if you just hit 3 times, there we go, any family doctor can predict which of their patients is likely to end up in hospital in the next year. Any community-based chronic disease nurse, And in fact, any Meals on Wheels driver can predict who of their clients will likely end up in hospital in the next year. We have a colleague, Sharon Anderson, who works in care of the elderly, and we were fortunate to work with her to be able to combine social data with medical administrative data to try and predict hospitalization. And once we did that, all became clear. And of all of the social factors that were able to predict hospitalization, one really stood out. Next slide. And that's this one. Turns out that we could predict hospitalization by looking at many social factors, but the strongest social predictor was actually loneliness. Next slide. You can see here the UCLA loneliness score amongst seniors in Edmonton was the best predictor of hospitalization, way better than any medical predictor. Next slide. So what does that mean? Do we treat loneliness by putting people in hospital or having them come to a clinic? Is that our treatment for loneliness? Or how do we actually address loneliness? Well, you can imagine we don't have a formal system for addressing loneliness. We can use the volunteer, not-for-profit, charitable sector, including just individual relationships. Next slide. So there are healthcare systems. There actually are some accountable care organizations in the United States who hire people to go out and visit some of their clients to address loneliness. So we could set up a whole other system of hiring people and having to go from the government to go out and address loneliness, or we could use existing structures such as volunteer groups, charitable groups, or even at individual level, having tea with your neighbor, as we heard, as a way of addressing this. Next slide. So I want to talk about another example briefly, Drive Happiness. So at the beginning of COVID, Alberta Health Services had 14,000 people who volunteered for us. On day one of COVID, our powers that be told all of these 14,000 volunteers to stay at home, not to come in. What they didn't realize was with the law of unintended consequences, some of these people happened to be drivers who drove people to important appointments like cancer chemotherapy, radiation therapy, dialysis. And all of a sudden we had none of these drivers. So in Edmonton, the organization Drive Happiness stepped up and they started driving people. So Drive Happiness provides subsidized and low cost driving to people in need. Next slide. Turns out that if you actually survey seniors, you find out that the number one need that they list is actually transportation for a variety of purposes. So next slide. And so Drive Happiness, by interactions that we had with them over COVID, where they really, really stepped up to the plate to help fill in this gap of transportation. And once we realized the importance of transportation, for example, up to 11% of specialist appointments are missed because of transportation issues. When we realized the importance of transportation and they realized their power, next slide, we've now been able to spread across the province to address transportation issues. And this is just by our back and forth interaction with Drive Happiness between the healthcare system and volunteer sector. So next slide. And just finally, going back to 26,200 not-for-profit organizations in Alberta, that's 1 to 160 people in our population. We worked with the city of Fort McMurray, who I think you're familiar with, in northeastern Alberta, home of the oil sands, where they had 750 not-for-profit organizations. That's one organization for 90 people. So how on earth does the local health system work with so many organizations? Next slide. Well, what we found out was that our principle was do provincially that which makes sense to do provincially, do local or zonally that which makes sense to do in zones or regions, and do locally that which makes sense to do zonally. And I've given some examples of how we work at all three of those levels. I'm just going to skip over those. Next slide. So how do we as a health system work with the volunteer sector? Well, as you heard, one of the most important things is sharing a vision and sharing also current understanding. So knowing where we are, where we want to go, that has really been the key to enable us to work with the volunteer sector and for them to work with us. And then, of course, we need a mechanism for that cooperation, collaboration. So we have committees at the provincial, zone, local levels to work with each other. But I'm going to translate actually the next bullet point of accountability to actually co-design between the system and the volunteer sector. For a healthcare system, we like to be in charge. We like to be, have that accountability to our CEO. We're in charge, we'll direct things. But turns up that feels very uncomfortable to give up power. But interestingly, when we give up power, we actually gain power. So we're accountable to each other, work with each other as equal partners, and we can do amazing things. So just in conclusion, we're grateful for our ability to work with the volunteer sector. They provide amazing services and resources. However, they're experiencing the same things as everyone in the world is in terms of shortage of volunteers, challenges with being able to hire the paid workforce in the volunteer sector, difficulty with scheduling challenges. People want to work when they want to work, just like employees these days. And sometimes we have to remember again that the volunteer groups that work with us voluntarily. So again, we want to be appreciative and kind to them for all of the care that they help us partner with. So thanks very much.
Wow, thank you, Richard, for those fantastic examples and summary of also how to leverage and tie in to voluntary support. And there've been a couple chat items around even thinking about creating more regional or based models as opposed to organizational based models of volunteerism, which might be very, very interesting, creating opportunities to share. And I think that's some of the examples you had. We're really going to step away and have a different view now. Scotland has had the development of integrated health and social care boards now for about 7 years. And we are very fortunate to have the chief officer of the Dundee Health and Social Care Partnership to talk about their work and how they have really built on community engagement and engaging with volunteers in the community. So Vicki, please join us and maybe share some of your.
Okay, thank you so much for inviting me to join you. Thank you, Richard, for your slides, which took me down memory lane. When I was 16, I worked my summer across Canada and didn't get any further than Edmonton once I discovered the mall, which was very different from anything I'd ever seen, certainly in Scotland before. So it was really nice to see references to some of the places I know quite well. I think, as I was introduced before, I'll just kind of go over a wee bit more about my background. My name is Vicki Irons. I am the Chief Officer of Dundee Health and Social Care Partnership, also known as Integration Authorities. There are 32 of us in terms of integration authorities across Scotland. As of next year, I will have had 30 years experience in health and social care management across Scotland and across the UK. And for those of you who don't know the background, Scotland has seen 3 series of reforms which have tried to integrate health and social care across the spectrum over the years. And I've certainly been in organisations who've gone through those series of reforms. The most recent of which, though, was the introduction of integration authorities in 2015. I think we can go on to the next slide if that's okay. So I thought I would just spend a minute or two giving you a wee bit of background in terms of what that means for our third sector partnership. As I've mentioned before, we've been through a few series of policy reforms prior to this. And one of the main underpinning drivers for the most recent reforms were to ensure that the full breadth of the partnerships that are spread across our communities became part of the new integration authorities. So when we were formally established, we were required to set up integration joint boards. We were required to put through what's called a scheme of establishment through to Scottish Parliament, which were considered. And we were also required to set up a strategic planning mechanism, which involved all of the partners involved in health and social care across the city. So for the third sector, that meant that we have a formal seat on our joint board for both carers and the chief executive who provides leadership across our bodies that, if you like, are the umbrella bodies for the voluntary sector. We have DVVA, which is the umbrella organisation, and the chief executive of that sits on our board. And in addition to that, in terms of carer input, we also have quite significant networks of people that use all of our services, and they have an equal seat, if you like, in terms of the membership of our planning forums. But that's not to say that there wasn't any level of input prior to the introduction of the IGBs. It's been very present in terms of the culture within Scotland for many, many decades. So that's a wee bit about health and social care integration. It was described early on as a movement of partnership rather than just an organisational reform of the public bodies which are established in Scotland, which include local authorities who oversee all of social care, and our NHS boards who provide all of our national health services. The idea behind the health and social care partnerships was to make sure that there was equity of relationships, but also equity of input and experience into our decision-making processes. And I have to say, from my own perspective, they've been one of the deciding factors which has enabled us to flourish and become the organisations that we have. So just one more thing on this slide in terms of my own overview of the importance and the pivotal role the third sector plays, particularly in the provision of health and social care across the city and Dundee. And that's really about the challenge ahead. I'm sure these challenges are probably felt by most people in health and social care systems, but certainly within the last year, we have witnessed an unprecedented change in demand for our services. We have seen a 20% increase in the level of care which we provide in people's own homes. But actually, we also have data which records what we call our unmet need. And that's currently showing that we have 4 times the level of demand than the supply that we have for providing care in people's own homes, which is of considerable concern. And inevitably, that burden of care falls on particularly carers and family members and unpaid carers to provide that level of input to be able to maintain people in their own homes and their own communities. In addition to that, a phenomenon that we've seen across our acute sector, particularly in recent months, is what we describe as our take, particularly through emergency care. We've seen a 25% increase in the number of admissions to acute care. There's thinking behind that a lot of that might be deferred demand as a result of the pandemic. And certainly we've had to reduce a lot of our elective activity throughout that period, which has translated into many more people presenting in our system as emergency cases, but also with much more complex needs. And our frailty indicators are showing that the needs of our population are changing way beyond any of the predictions we had that were aligned to demographic change. So I guess within that, what I'm trying to say is there is no way on earth that the public sector funded authorities have got the capacity to respond to that level of demand. Even if I was to employ every school leaver in Dundee City within the next 5 years, it wouldn't provide the level of workforce that we require to be able to respond to that level of need. So we have to build what we describe as the capacity to care across our third sector partners and across the city. So I think we can move on to the next slide. So before I joined you this evening, I asked my leadership team if they could give me a few examples that they would be happy for me to share with you. And I have to say, I said in the run up to this evening's opening, I was inundated with examples, which is a really, really fantastic, I think, reflection of the activity which is underway. Many of the developments we've seen in Dundee City actually are award-winning. It doesn't harm to be the best is my motto when it comes to developing new initiatives. But so some of the examples I share with you tonight have been recognised both through Scottish Government and COSLA, which is our organisation which overarches our local authorities as well. But there are many, many more behind these slides, and I'd be more than happy to share those with the network if it was felt to be useful. So the first example tonight is an award winner in terms of Partnership in Action. And we were the runners-up in the Voluntary Sector Partnership Award, which was hosted at Scottish Parliament very recently, and a fantastic evening. And that's about what we describe as Dundee Safe Zone. Dundee Safe Zone was initially launched in 2019, but actually came into its own during the pandemic, and essentially provides care and support and a cup of tea and something to eat in all of our neighbourhoods across the city, and particularly during the pandemic when people were required to stay at home. This was the only presence in some people's communities that was there. It's open to everybody, and anybody can come just to have a chat, to get a warm cup of tea or coffee, but also to get the support of our voluntary sector and some of our partners in the statutory sector as well. Next slide, please. And this is just the worst possible description of a service in terms of the letters you see at the top of this slide, but hopefully the slide itself gives you an overview of the work we do around drug and alcohol use as well. But we also launched in 2019. Many of these were launched just before the pandemic, which again really came into its own, the Dundee Non-Fatal Overdose Rapid Response Team. And rather than read out the slide, I'll just give you a reflection of that. But essentially, we have a completely integrated response team now, which provides support for individuals who've experienced a non-fatal overdose. And the aim of that is to try and reduce rather an unwelcome record that we have in Dundee as having significant amounts of drug-related deaths, but to ensure that people and their families have the opportunity to engage with the voluntary sector and with our public sector to ensure that they get the treatment and care services that they need, and most importantly, to prevent future incidents of drug overdoses. This has been developed more recently to be trauma-informed as well, in terms of us understanding the underlying issues which can often contribute to a non-fatal overdose. Next slide, please. And one of the other examples I wanted to give you, and this is probably the worst slide in history in terms of its lack of focus, but there's a link on here in terms of the web link, was developed with Dundee Voluntary Action, and that is essentially to make sure that we have a response available across the city which responds to lots of the social isolation and the loneliness that was mentioned earlier on in the workshop today. And this was developed by a leader within Dundee Voluntary Action, and it essentially is a portal that's web-based, which provides links as a one-stop shop to all of the different community groups, all of the formal support mechanisms that we have in, and every other item that's available to people, particularly initially targeted at the frail elderly across the city, but we've now extended it because we've had so many people contributing to this one-stop shop approach so that it covers all adults. It's not a resource which is targeted at younger people and children at the moment, but where we have that under development as well. So just some great initiatives. And essentially this was described to us at our strategic planning board as the front door. And I think that's one of the most important things that I would like to leave with you today, and that's that this has completely opened up access to the right care and support that people require. And it's definitely not based on an overly medicalized model, but it's essentially what people need.
Brilliant. Thank you, Vicky, for sharing those really amazing experiences and the activities happening in Scotland and Dundee. And so I think enthused that many of them are very translatable and could be transferred to our implementation in our jurisdiction. So I think that was very, very helpful. Thank you for sharing those. We're going to move on to Brian Ludwig Fruit, and I would just encourage people to continue in the chat. There's some great conversations going. We're going to come back to them after Brian shares a few words with us, and maybe we'll also come back to this social isolation and volunteerism. We've also started to develop some evidence around patient and caregiver experience related to that. Brian, please share with us your experience and some of your perspective on volunteering. Welcome. You might have to come off mute here just for a piece. I don't think you have prepared slides, so we can just have you speaking directly.
Yes, sorry about that.
Welcome.
Thank you for having me. I have to say that this has been an incredible experience in the last hour. I have been trying to listen totally to the speakers, but this incredible information is going on in the chat at the same time. And I realize that I can't multitask and do both, but I'm really glad this is being recorded and chat and captured, because there is so much here. So I think just some of my remarks are going to be informed by the previous speakers. So I hope that I can tie this together in a way that makes some sense for everybody, just from the caregiver's perspective. In my introduction, you heard that I have been a caregiver going on 7 years now, and a full-time caregiver. And I'm really mindful of the voluntary sector for a number of different reasons. So the first is in the province that I live in, which is Ontario, 80% of all care that is given to seniors in the community is given by caregivers. And 30%, and I would venture to say that, like Vicky said, and what's changing in her community, the most recent data I have is that 30% of services in institutions are provided by informal caregivers. And I would say that with everything that we've been seeing in the medical system recently, I'm sure that number has gone way up. So, but and frankly, it would cost at least $26 billion annually to replace the work of Canadian caregivers in caring for seniors. But as I was listening to this, and I was listening to what Michelle's the data about the change in numbers on volunteers, I thought of myself as a caregiver for the last 6 years, but I really hadn't thought of myself as a volunteer in such a strong way. So you're sort of I'm reframing as we go. So a few things. So interestingly, I've been working with the healthcare system for the last 6 years, and I had never actually heard the term third sector before. So it's very interesting to hear it and to hear how it's being used. And, it's interesting in reflection on some of this. One of the things that I realized is that if you need a service and someone tells you about a service, you actually don't know if it's a voluntary service or a paid service necessarily. If it's something that comes through the medical system, and then you don't know sort of where else it comes from. But as an example of, and I'm going to talk a bit more about things that we don't know. So the fact that this knowledge sharing is going on is so incredible. But my mother-in-law was a post-polio survivor, and it was actually the March of Dimes who installed at no cost a staircase, electronic staircase into her home, and made me realize sort of more about what some of those voluntary organizations do. Because as you've all been speaking, everybody is acknowledging that healthcare, and when I think it was Richard who talked about that the amount of healthcare that's actually formal is such a tiny bit of it. But when you're a caregiver and you're trying to coordinate this, it's social, it's emotional, it's physical, and you're trying to understand where all of these things work. And again, in Richard's presentation, there was something about, it's not that we don't have the services, but it's that we don't know about them, or we don't know how to access them. So one of the things that I have been thinking about a lot in my caregiver journey is, wouldn't it be great to have a concierge or a a personal assistant for caregiving. And so I throw this out here. I know we have a very complex system. I know that it's very hard for people to sort of integrate care, but one of the things, as someone who is both a volunteer and a caregiver, is you don't know what you don't know. You don't know what may or may not be out there, and you can be too overwhelmed to even access it when you do know. And I have long thought that perhaps there is a job match that can be created at some point of that kind of concierge for integrated care, so that there's somebody who's on this journey with you who can help. So I ask you all just to think about that, whether there's a possibility. But, you know, I will say that to Vicky's point about the fact that they have these unmet needs that they just can't get at, it's actually, this won't surprise anybody, it is terrifying to be a caregiver of someone whose health will eventually deteriorate in a health system where you know that there are not a lot of options. So the idea that people are talking about this and looking at integration and looking at this loneliness issue is absolutely tremendous. One of the things that's interesting, and I noticed someone on the an attendee is on this. My building has just been declared a NORC, or a naturally occurring retirement community, and one of the things that we're struggling with, and so I did see some of these comments related to the drivers, was we want to be able to do wellness checks on people, but not social wellness checks. So we want to be able to figure out some kind of system to just make sure that people are waking up every morning. We have other provisions to put in social activities. But so I'm going to ask this of the audience, that if you know of any digital or technology-based system that can contact people and do an interconnection, just to make sure that people are okay, I would so appreciate hearing about it, because there are two things. So when you talked about the drive, people are risk averse to being responsible for following up with an individual to make sure that they are okay when it's a neighbor. And the other is, and this is the challenge, is that with all of the loneliness and the isolated people, that you want to know what you're getting into. And if you're getting into a phone call, you need to know that that's a fairly substantial commitment. And so looking at where technology can help would be very helpful. So the other thing was the drawing that Michelle had of the evidence of the expectation of health impact and the reality of health impact, with the straight line versus the completely twisted line. And I will say that A, that is absolutely true, and B, that that is often what people who are in the midst of this crisis feel is happening to their brain, when there is so much that is confusing and hard to deal with, and you're just looking for someone who can sort of give you some help to figure out how to connect the dots. And so the fact that there are so many people working in this integrated healthcare and connecting the dots is absolutely amazing to me. So the only other thing that I'd like to say is that as part of the knowledge sharing, and I love that front door. If there was some way of getting a tips book, and yes, the entry level could be the family doctor, it could be the hospital you're in, it could be, but that just shares that knowledge of what might be available, I think it would be used so incredibly. And when I think about that, I think that, you know, when you think about the volunteer sector, it's not just the agencies, but it's the things like the parks. It's where we go for our exercise. I think I'm getting the signal, so I'm going to wrap it up. except to say, I hope this was of some value, but I got so much out of this and the chat and hope to get more. So thank you all very much.
Wow, what a great opportunity. And thank you so much, Brenna, for sharing. You have been such a wealth of information and knowledge in this last few minutes. And so I'm glad we'll be able to capture this and carry it forward. And the chat has also been, many people have been adding some resources. So right off the very top, I know Michelle said there's a systematic review. So Michelle, you're going to send that around on the effects of volunteerism. And there's been a chat running between Michelle and Cheryl Cameron in particular around evaluation, which we might come back to. But I appreciate all of the resources. People are also sending in links. And we'll collate them and add them to the end of the slide deck before we mount the slides up onto the website. I really want to first off thank all of our speakers, and I'm going to invite them each to kind of come on screen. You can come your videos back on, and you might be able to speak, because many of these questions that have come up have come from different aspects, and each of you might have some opportunities to comment on these. So I mean, I noticed that there was someone was, I think it was Cheryl Davis early on, asking about more supports for caregivers and perhaps, some group that might make provincial education available for caregivers and how we get that out. And then Usman Aslam had noted that they were supported in an opportunity to receive caregiver training through a volunteer organization. So Usman, can you please put that link in for us or send it to us after so we can contribute to it? That's exactly the kind of exchange that we're seeing here that is of great and considerable importance. And I'll say I timed out a little bit on the chat in the last few since I've come back on to start hosting again. So I see the last few coming in. Many people wrote in about their experiences, about their own volunteer experiences, and then some other things that were going on in their neighborhoods. Judith Carson around Wellington County and the VON providing transportation vehicles to move around. Janet Johnson talking about the financial assistance and donations coming from voluntary groups. And I've seen this all the time with the bake sales and the events that people put on, and then those monies come in as donations to the health and social care sectors. So where would we be for quality if without those additional resources? So really acknowledging many additional pieces. I've got a couple others, but maybe, I don't know, Jodeem, if you had noticed some that you might want to raise off the top.
I do. One of the things that is coming up in this conversation, but comes up in many, is the significant shift we need to make from, I'll call it egocentric to ecocentric, where we have to challenge ourselves to stop thinking in terms of self and organization and shift to the ecosystem. And when we do that, we have another shift that has to take place, which is a shift in mindset from scarcity to abundance. And abundance theory says, and I believe this to be true in all the work we do, and it comes up in the chat conversation around the volunteer sector, is that every organization has different resources and different capabilities, which includes volunteers and the third sector. And what if we aligned resources around the common goal, population health and well-being? What is most important to caregivers and families? And volunteers worked in shared purpose to address that. And much of the chat did talk about aligning and leveraging the opportunity to create communities of volunteers. Integration and population health challenges the way we are structured and all the processes we have in place, and flips it on its head to the collective. And it really is coming out loud and clear. Then the volunteer sector do the same. Then the conversation arose around sharing evaluation, leveraging our capabilities. And you can see the capability and resources we have with 130 people that are on today. Already we're sharing knowledge, building resources and capability. Well, the same holds true in understanding the needs of caregivers, and what Bryna has said is most important to her and other caregivers in North America. Same issues arise around support, around remuneration, and Wojtek brought up this piece around remuneration for volunteers. And when Dr. Howard Abrams was on, he asked a really important question too around what he called micro volunteering and solutions to the siloed nature of volunteering, and how to incentivize people to break down barriers and create a broader collective. And so the knowledge we are sharing, and this virtual community is a testament to the capability that already exists, if only we would take time and space together to learn and share resources. But then this shared reflection allows us this collective consciousness, or this collective understanding that we all spread our wings and take forward. And that's some of my reflection from the conversation. And I believe now we would like to go to some of the questions. Walter. You're on mute, Walter.
Doesn't happen very often to me, in spite of what mothers might prefer. I've got one that has been peppered in the chat at various points in time, I think along the way, but there was certainly a comment towards the end, and I'm going to interpret it this way, around understanding what we can count on from voluntary sector, and a little bit around accountability for that, and what might be done. So actually, I want each of the panelists to give a bit of a perspective from each of your perspectives. So I'm going to go back through, and I'll go back like directly in the same order with Michelle, Richard, Vicky, and then Bryna, to comment on that a little bit. What's your perspective on this accountability, and how that might mean for what we know we can and can't do, and also patient safety and quality, and caregiver safety and quality?
It's just a small question, Walter.
Well, just give me like one or two little bits.
Yeah, so as you asked the question, and I'm sure I'll just touch on one or two things that jump into my mind. So I think so much about, and this is Howie's point too, about building systems of volunteerism that, one, recognize and value the contributions of the individual to the service, but also creating space. So to Jodeem's comment about sharing power and new ways of thinking about the collaboration, volunteers in the voluntary sector are often relegated to nice to haves or additional, or they become task and cost shifting agencies. They're providers, not partners. And so it's complicated to think about, and makes people very nervous to build systems and services that are highly dependent on a voluntary sector and a volunteer workforce that can't be quote unquote mandated and controlled by HHR, Health Human Resource Processes. I'm going to leave that sort of,
Leave it out there.
Statement, and sort of maybe we can spark some conversation around that.
Yeah, I'm interested in the audiences and the participants today joining us and your perspectives along this line as well. But maybe first go to Richard, then Vicky, and Bryna, and then Jodeem, will come back to you, and then you might have a question to raise too.
Well, I'm glad Michelle went first, because I was hoping it would buy me some time to think. But one of the areas where I'm torn is I'm a big fan of Cormac Russell and asset-based community development, and his comment would be, well, why do we need volunteers? So right now in Canada, where it's snowing, and we now have all of these groups that will do voluntary shoveling of the snow. Cormac's comment would be, what's wrong with the teenager next door? Why do we have to have all of these organizations, 26,000 in Alberta, that are formal organizations to do this? So I suppose in an ideal world, if people help people, neighbors help neighbors, we might not need that, but that's not the reality. The reality is we do have need for some of these services, and we can choose to pay for them as taxpayers, or we can, as citizens, be part of the solution. It's often said that a healthcare system is just people looking after people. And so if you think of it that way, then volunteer organizations may make sense to be able to do things that are needed for our fellow citizens. So I think it's a little bit of that. I think what Jodeem was referring to, that reframing of our thinking. And particularly from a health system perspective as well, recognize that, again, this is just another form of help that we're receiving, that we want to certainly, as I said, be grateful, appreciative, work, in a collaborative manner, share the power, so to speak. So I guess it's, some of the care is paid, some of it is unpaid, but it's all equally valuable.
Yeah, thanks. What's been your approach in Scotland, Vicky?
So I think this is a really interesting subject area, and to be fair, it's probably been dominating all of the discussions around establishing more formal arrangements around the third sector in Scotland. And I'm very mindful of a whole series of conversations we had probably a good 9 or 10 years ago now with senior politicians who were very, very concerned about what they described as ensuring quality and maintaining safety across the contribution of various partners across the third sector. I guess my own reflection would probably be a little less controlling, and there is something here about not seeking to project the systems and the checks and balances which we have across our statutory public sector duties onto the partnerships and relationships we have with the third sector. And I can just think of so many situations where we don't have an overview, we don't have a line of sight, and we don't seek to check the quality of care that's provided. You know, the 16-year-old who pops around to see his gran and granddad every day and makes sure that granddad's taking his meds and, you know, stays over occasionally when you know, his granddad's more confused. He's a caregiver, he's providing care, and we don't seek to if you like, govern that, because that's just seen as being a good family member, a good neighbor, a good community member. So there is a line though, and I think it's particularly when we have third sector organisations that become formal providers of service. So we have a number of larger third sector umbrella organisations that actually pay a formal contribution to care packages that we provide, particularly on discharge from hospital. And in those cases, we just try and make sure that our commissioning framework has the most appropriate checks in place to make sure that that's of a specific quality, but that also the people that are performing those roles are not going to present any further risk into the system. And we've got quite a robust public protection system in place in Scotland that enables us to oversee that side of things and to make sure that we're not necessarily putting vulnerable people in more vulnerable situations. So there is a framework which surrounds that. But as is usually the case, there's an entire spectrum of contributions to be made. And I certainly think we have to be careful to overregulate that. Otherwise, we'll lose the potentially excellent contribution that can be made by entire communities.
Yeah, those are very, very thoughtful words. And I don't think there's an easy answer, which is why I asked the question. I only get one question. I want it to be one of the more challenging ones. Bryna, and I see some chat here too that people, you know, some other comments, perspectives that I don't disagree with.
Yeah, I think I may be less able to comment on accountability and more able to comment on engagement. And so there are a couple of things that I would really think about. I happen to work with a charity that works in youth engagement and getting younger people involved. And one of the things that people underestimate about younger people is that they are actually very generative and they want to leave the world a better place. And so part of this may be in how we engage with younger people in getting involved with this. On the other side of this, though, I want to give an example of my role in the PFAC, which is a voluntary role. And we do important work. Like, we are highly respected as caregivers and family people, but we get asked about, like, we were formed during COVID, right? We are about visitor policy, about harassment of staff, even, you know, how do we communicate on patient treatment? And I would just say that awareness of mutual respect and valuing your volunteers goes such a long way towards engagement. But I did see Michelle's comment, and you know, I do worry that my demographic has a big commitment to volunteerism, and we're just going to be moved into the vulnerable like real soon, right? And so we really do need to look at how to replenish this.
Yeah, great. Thanks. Jodine.
That's wonderful. As everyone was responding, and I'm looking at the chat, I'm thinking about a couple things, and then I'm going to share what I'm thinking, but pose the question first, so the panelists have a second to put their thoughts together. Based on this conversation, based on your experiences, and based on what you're seeing in the chat, perhaps a lesson learned today that we all need to take forward from your perspective. Before we go there, though, there are a couple pieces I want to punctuate that were mentioned. The first is the third fundamental shift, which is all the assumption around volunteerism and what is meaningful. Most important to ask what is meaningful for volunteers. And that shifts the power to the people volunteering to define what important looks like, and also to respond to the needs of people and families in communities. And the most recent chat really highlighted, Murray, I think it was you, who said, there's been a professionalization of volunteerism, and you don't want to go back on it because that helps enable and support volunteers. And at the same time, we want that reorientation so that, as Bryna said, it's not only about social engagement, it is about meaningful connection and, for instance, how a wellness check would be defined. So there's another shift for all of us as we're thinking about moving forward together to reorient a broader, more sustained and scaled perspective for impact. Brian, if you're okay, I'd like to go to you first. Based on all of this, a lesson learned that we should take forward. And everybody in the chat, please share yours as well.
Wow, thank you. But lesson learned, there is stuff happening. So I guess that my lesson learned is that knowledge sharing is huge power. Because how else would we know about what's happening in Alberta and what's happening in Dundee City that is actually scalable or applicable to other communities. So for me, I think I will be left with that that front door concept of Dundee City, and how do we think about that as a way of helping people here in Canada, where probably the jurisdictions are bigger.
Thank you. Vicky.
I think for me, it's about celebrate success. And I didn't really recognize that or understand that until we opened up, if you like, award ceremony season again, post-COVID. But there's something about recognizing where there's been a movement and momentum of its own and exactly what it's achieved. Because actually, truth be told, until I asked for all the examples to share with you guys today, I didn't really know the detail of half the things that had gone on in my own city. So there's something about, communicate and celebrate all of the things which can be achieved, because I think that just helps build confidence across others who want to make a contribution.
Thank you. Richard.
Well, as contemplating, I use the term volunteer sector, and we've heard of third sector, and I realize that's not probably the right terminology to call it a sector. I think, it strikes me that volunteerism really is that embodiment of people looking after people. It's recognizing a need, people joining together to try and address that need. So there's that balance between the need for organization, coordination, and then the balance for meaning, for flexibility to meet those needs. So it's a challenging area, and one that I think need to pay a lot more attention to.
Thank you, Richard. Michelle.
Yeah, I would agree, Richard. I think this conversation and the takeaways is that this is a topic of tensions, formal and informal, meaning to whom, reward for what, organized local, hyper-local versus system level. And it's a topic of tensions and one that warrants a lot, I think, a lot more discussion. And that's not just me saying it. The IHI, King's Fund, Burrell Institute have all come out with clear statements to say, if we're going to move to really meaningful health system engagement, integrated care, we need to think about the role of volunteers and the voluntary sector. We have some opportunity to shape what that looks like and what it means.
Thank you to all of you. To punctuate a final point, and then we're going to go to a couple. We want to do a pulse check on how you feel, your knowledge, if it's shifted at all since the beginning around this topic. But the way I would summarize what has been said so far and can be achieved time and time again for exponential impact is, first, we have to look up and look out. We don't often realize the capability and how many resources and skill is available, but we have to create the space to connect and to connect broadly. Our role is to convene the space and allow that connection to happen. It does not need to be pre-planned to share capability. If you look at this hour and a half, what we have achieved together, it is probably more miraculous than we're able to do in traditional approaches. So please feel free to share the approach and so forth. We will be curating all this material so you can share broader. Let's do a pulse check and launch a poll, and then we're going to have an evaluation question before we close. So thank you for staying with us for the additional 4 minutes. The question that we want to ask you about today, Deb, are you able, or Fiona, are you able to launch that?
Apologies, I'm just being slow. Here it comes.
Okay, so the question is going to be, as a result of today's session, how knowledgeable are you now about the role of partnering with the volunteer sector within an integrated system? We are wanting to really understand how the design and delivery of a very interactive session across all of us helps build our capability, helps increase our access to knowledge, helps build relationship with one another. So thank you for each responding to the poll. And Fiona, if it's close, could you please share the results?
I'd say we've definitely had an upward shift there, a lot more 7s and 8s.
Yeah.
Very few choose one. So what a great opportunity for everyone to come together today and joined us. And I think even just from sharing the knowledge that we already have within us, in many cases, very, very helpful and resourceful. We could come back to the slides. I think there'll be an opportunity to bring up the note around upcoming events. So first off, I want to really thank and appreciate everybody for coming out today. And watch out for future virtual community announcements and information. We are going to have a session in January on collective governance, again, with some knowledge base from research and experience base from the field, January 24th from 12 to 1:30. We'll have the registration page up for that in just a few days, along with the video and slides from today. Welcome everybody to come back to join for that one. And I think we also have one piece, and Jodine, this is your call.
We would welcome everyone to share one word. We call it a snowball. Share one word that describes your experience today as you sign off to leave. Dipti says connected, Cheryl engaging. Thank you to Dipti and Cheryl for all your contributions. Anam, inspired, hopeful, inspiring, inspired, informed, thoughtful, informative, inspiring, proud, engaged. Excellent. Look at this. We all brought this to life. We all had a voice today. This is what sharing power is about, convening the collective and enabling the collective for impact. Walter and I cannot thank you all enough for joining us today. We hope not only have we sparked a light, but you have more resources and more capability to take this forward. And the whole point of this work is that we are inspired, we are re-energized so we can continue to work together and actually make an impact that matters. Thank you for being with us today, all of you.
Take care, and we'll see you again next month.